Hi, so let's talk a little bit about what we do with TMACS output, how we use it in emergency departments in hospitals to direct patient flow, and how we're going to use it in ambulances to direct patient flow. So in hospital, if the calculated probability of ACS is less than 2%, then we assign patients to the very low risk group, and those patients are eligible for immediate discharge. If the probability is between 2% and 5%, then we assign patients to a low risk group. Those patients are going to need a second troponin level before we rule out ACS, but the chance of it being positive is quite small. So those patients are suitable for care in an ambulatory environment like the clinical decision unit or an ambulatory care unit. In my opinion, having this low risk group was really important for helping TMACS to work when we first implemented it, because it meant that we could direct patients to the ambulatory care environments where they sit in chairs and they're geared up for discharge, which is what happens to the vast majority of the patients who are well, rather than a bed in an acute medical unit. Once you get there, you have a lower frequency of ward rounds, you tend to stay for longer, the patient gets their pajamas on, and the length of stay tends to increase. By avoiding that for the lower risk patients, we can turn them around much quicker. If the probability is between 5 and 95%, then the patient is classed as moderate risk. So those patients are still admitted under the acute physicians at Manchester Royal Infirmary, and we divide that group into two. So we have the patients with abnormal ECGs and high troponins, and they'll go to the acute medical unit in a bed. And then we have the ambulatory moderate risk patients who are still suitable for ambulatory care, but they might need a little bit more workup. For example, we might be able to offer them an ambulatory CT coronary angiogram within the next 24, 48 hours, for example, which is a really helpful service. And finally, if the probability is at least 95%, then we assign the patients to a high-risk group. Those patients can be referred directly to cardiology, have treatment for non-ST elevation, acute coronary syndromes, and can be referred directly to cardiology. So how would it work in ambulances? Well, the pathway would be fairly similar. If your probability is less than 2%, then we'd assign patients to a very low risk. And in the future, those are the patients where we'd hope to avoid unnecessary conveyance to hospital. And we'd use a shared decision-making approach and make sure that we've got appropriate safety netting arrangements to ensure that the patient can be left at the scene safely and still have access to help if they should need it. Low-risk patients would still be transported, but they could bypass busy and crowded emergency departments and go directly to ambulatory care environments, such as same-day emergency care units or perhaps urgent treatment centres or urgent care centres, where they could be looked after and have perhaps a repeat troponin test at the unit to make sure that everything's okay. So they'd still be conveyed, but they'd go to an ambulatory care environment. Then we have the moderate risk patients. So that would be the patients whose calculated probability of ACS is between 5 and 95%. Those patients would still go to the emergency department. So their care wouldn't change. We estimate that that will be about a third of all of the patients though. So most patients would have their pathway changed and hopefully improved by the use of TMACS. And lastly, we have the high-risk patients. And the benefit for the high-risk patients would be that we recognise that they're likely to be having an NSTEMI early, and we could bypass local centres and take the patients directly to a heart attack centre where they could receive the appropriate treatment, including coronary intervention. During our pilot project with the North West Ambulance Service, we're not going to be making those changes right away. So the changes to the pathway are more subtle. The goal of the project is really to get point of care troponin testing up and running in the pre-hospital environment. Patients will still see improvements to their care pathway because if the patient is very low risk or low risk, the paramedic can communicate that to the triage nurse on arrival in the ED, and the patients can be rapidly streamed to the same-day emergency care unit, which means that we have better risk stratification to the SDEC, and patients will receive more efficient care. For the high-risk patients, we'll also be able to identify them very early so that they can avoid waiting in corridors, hopefully, avoid being sent inappropriately to waiting rooms. They can go to amber areas or resource areas of the emergency department, and the staff can review them early and refer them on to cardiology early. So that's a quick rundown of how we hope to use TMACS to improve patient pathways in the North West Ambulance Service as part of our pilot Advanced Diagnostics Accelerator project.